Hi students, hello, how are you all doing? Am I audible? Am I visible? If yes, then just say hi or give me a thumbs up and we are going to start as soon as you give me a go ahead. Yeah, hi. Is anybody live today? Is anybody live for the class? If yes, then they can give me a thumbs up. They can tell me if they can hear me fine. Is anybody live for the class? Yeah, I think the sound is pretty okay. All right. So I'm going to start, and today we are going to discuss oxygen delivery devices. Now, this is a very practical topic. We hardly see any theoretical questions from this topic because it is all about understanding the stuff and understanding the way we deliver oxygen. So I'm going to discuss the concept behind oxygen therapy, and we are going to discuss the common oxygen delivery devices, right? So let's start with the first part of the discussion. That is, what is why do we need to give oxygen to the patient, right? The first part of the discussion is obviously why do we need to give oxygen to the patient, isn't it? Have you ever thought about it? Why do we need to give oxygen to the patient? See, oxygen is required for metabolism. But where? Metabolism at cellular level, isn't it? At cellular level. So it is required for metabolism at cellular level. So if oxygen is present, the type of respiration that our cells show is called as a aerobic respiration, and the byproduct of an aerobic respiration is ATP, which serves as energy for other body functions. That serves as energy for other body functions, right? This is the concept behind oxygen. Why do we need oxygen? Is it required for our sustenance? Yes. If oxygen is not present, then the body goes to anaerobic metabolism. And anaerobic metabolism also produces ATP, but it is not that effective a process. But at the same time, it produces a lot of lactic acid as a byproduct, which can cause lactic acidosis, which will eventually start deteriorating the cellular mechanisms and cellular functions and mitochondrial functions. And ultimately, the cell has to die. So hypoxia causes death at tissue level. Hypoxia is a problem. Hypoxia leads to tissue damage, and ultimately it will lead to death of the cells. And if enough number of cells have died in the body, then of course we will also get affected. So hypoxia is at the level of the tissues. Remember, the word hypoxia means tissue oxygenation. Tissues are where we have cells, and cells are where there is a cellular respiration. While hypoxemia is when you have less O2 concentration in arterial blood. You have less O2 concentration in arterial blood. That is hypoxemia. Try to understand the difference between hypoxia and hypoxemia. Now, whenever we say that the patient is hypoxic, this is something that you will get clinically very often. You will get a patient, you will look at the patient, you will find saturation is low, and you will say, okay, the patient is hypoxic. Are we using the correct terminology? No. Because what you see is the blood level of oxygen, which we call as hypoxemia. And remember, hypoxemia is not hypoxia. Hypoxemia is not hypoxia. Doesn't mean if the arterial concentration of oxygen is less than normal, doesn't mean that the tissue level is also less. At the same time, if the arterial level is normal, doesn't mean that the tissues are not hypoxic or the tissues do not have less oxygen. All right. This is something you should keep in mind. This is something you should keep in mind. Oxygen as a therapy is based on the fact that yes, if you do increase the arterial concentration of oxygen, you might be able to tackle the hypoxic concentrations or hypoxic effects at tissue level, but that is not always true. And we'll see later on which are the conditions where use of oxygen is not going to make a difference. All right. So when we talk about oxygen as a therapy, you have to realize that oxygen is also a drug. And since we use a lot of drugs, we know that every drug should have a indication. It should have a dosing. It should carry a proper prescription. Whenever you give the drug, there should be proper monitoring. And finally, you should look at the side effects of the drug. Finally, you should look at the side effects of the drug. So just like any other drug, even oxygen is considered as a drug, and these are the things under which you prescribe oxygen: indication, dosing, prescription, monitoring, and side effects. And we are going to discuss each of them. We are going to discuss each of them. Now, if anybody has come live, they can just say hi so that I know that you guys are here. And I'm not just talking to the camera. All right. So try to understand, if you treat oxygen as a drug, then just like how you're very careful while using any other drug, you'll be careful while using oxygen. As opposed to what you normally feel is that, especially in India, we're like, हाँ, oxygen to laga hi de. That is what we say. Suppose there's a patient. Yes, finally we have one person. Hello, Bhargavi. So what happens normally? If oxygen therapy means, suppose somebody comes to your OPD, is breathless and blah 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 blah, you shift the patient to the ICU, or you should go to the casualty to see a patient who is coughing incessantly, and you see that okay, the patient is toxic, maybe the patient has pneumonia. Oxygen to lagai de. Let's just start some oxygen and then we'll see. So what we do is we treat oxygen as it's like okay, normal, it's required for living, but no. Oxygen, when it is delivered, when it is given as a therapy, is a drug. And every time you use a drug, these are the things under which you should use a drug. All right. So before we go on to understand that, let's first understand oxygen delivery, because oxygen delivery will ultimately decide whether your patient is going to receive that oxygen or not. And you have to first understand the concept of oxygen cascade. Now, my anesthesia students, they know a lot about oxygen cascade because anesthetists is involved a lot in understanding the mechanics of oxygen. But you as respiratory physicians, you should also know what is oxygen cascade. So oxygen cascade is a step-by-step process which the oxygen passes through to ultimately reach the end point of oxygen, that is mitochondria. So from where are you taking the oxygen? Oxygen in air. To what is the final destination? Oxygen in mitochondria. And this oxygen is 21% of 760 mm of Hg, that is approximately 110 mm Hg. And what reaches at the mitochondria is 1 to 2 mmHg. So with every step, there is a sequential decrease in the concentration of oxygen. This decrease in concentration of oxygen is called as oxygen cascade. This decrease in the concentration of oxygen is called as oxygen cascade, right? So at every step, from where air to upper respiratory tract to lower respiratory tract to alveoli from alveolar capillary membrane to arterial blood. Arterial blood, it then goes to the level of the tissues. From tissues, it will diffuse to cells. From cells, it will diffuse to mitochondria. So this whole process, there is a sequential decrease in the oxygen. At every step, there is mixing of other things which will decrease the concentration of oxygen, finally reaching to the patient. That is oxygen cascade. And this oxygen that is being delivered, DO2, that is the global delivery of oxygen. It's a combination of cardiac output, that is the ml of blood which is pumped by the heart per minute, multiplied by the oxygen carrying capacity of the blood into 10, because that deciliter is converted into liter. All right. So it is global oxygen delivery. So if you want to deliver oxygen, what are the two factors that you need to look at? One, you need to look at the cardiac output, that is the amount of blood that is ejected from the heart, and another is the O2 delivery. Now, when you give oxygen therapy, then you are only talking about the O2 delivery, not the cardiac output. So remember, a very important part of oxygenation to the patient, that is delivery of oxygen to the patient, is also dependent on cardiac output. So suppose you have a hypotensive patient, a patient who is in shock. No matter you give 100% oxygen to the patient, the PO2 will not rise. The patient will not become better. The lactates will not come down. So you have to always remember that oxygen is not the solution to hypoxia. Hypoxia means at the level of the tissues. Understood? Try to understand. Why am I insisting on this fact is because as respiratory physicians, as anesthetists, as intensivists, we tend to always overlook the fact that you might not always be helping the patient simply by giving them oxygen. This is the backdrop behind which this whole oxygen therapy has to be understood. When you talk about the O2 content of the blood, then in blood there is a bound O2 and then there is a dissolved O2. Bound is to the substance which carries oxygen in the best form, that is hemoglobin, and every gram of hemoglobin carries 1.34 ml of oxygen, and depends on how much percentage of that hemoglobin is saturated with oxygen, you write SaO2. And then of course the dissolved is whatever is the arterial concentration of oxygen multiplied by whatever is the part that is being dissolved in the plasma, that is 0.0031. So Hb is the hemoglobin concentration in gram per deciliter, 1.34 is the oxygen carrying capacity, percentage oxygen, solubility coefficient for oxygen. So very small component of your delivered oxygen is actually going to increase your oxygen carrying capacity of the blood. Again, when you give exogenous oxygen to the patient, remember normal saturation of hemoglobin is 95%. This is normal saturation. So to make it 100%, you will only increase 5%. So when you give oxygen therapy, there is no much difference in the oxygen carrying capacity of hemoglobin. But what increases is this dissolved. But look at how much it is. It is so less that even if you give too much of oxygen, the dissolved oxygen content doesn't really increase too much. That is why we say oxygen therapy doesn't mean that the tissues are getting oxygen, right? Again, one factor to look at is hemoglobin. If you have low hemoglobin, automatically the oxygen carrying capacity of the blood will fall. So if your patient is anemic, no matter how much oxygen you give, the oxygen delivery will not increase to a level that is sufficient. All right. Now, we are talking so much about hypoxia and we are treating hypoxia with oxygen therapy. So why not to look at what are the signs of hypoxia? Now, if I ask you randomly that tell me if your patient you see in casualty is hypoxic, how will the patient present? You will tell me at least 5 or 6 of these things that are written. You will say, sir, the patient will have loss of consciousness or delirium or irrelevant talking. The patient would be very anxious. The patient will be tachypnic. The patient will move a lot. There is tremor. There is also a risk that the patient might go into seizure or the patient might become obtunded or comatose. The patient will not have a very good blood pressure. The peripheries will be vasoconstricted. It will be cold. All these things we will say. But when we have to write, we often forget this thing. So always correlate clinically. Whatever you see in your patient is what you write in the exam. So if you look at respiratory system, the patient might be tachypneic, dyspneic, cynost. In CVS, the patient might experience palpitation. Why? Because I told you global delivery of oxygen is cardiac output into oxygen carrying capacity. Now, for whatever reason, the oxygen carrying capacity has decreased and which is causing hypoxia. So the body will try to compensate by increasing cardiac output by increasing the rate of heart beating, which will now cause more blood to flow to the peripheries, and therefore the patient might experience palpitation. There will be increased cardiac output, there will be tachycardia, there can be arrhythmias, there will be hypotension, angina, diaphoresis, shock. In CNS, because decreased global oxygen delivery, there will be headache, confusion, euphoria, delirium, papilledema, seizures, obtundation, and coma. This is not all in one patient, but sequentially. In metabolic, you will see lactic acidosis, there will be sodium and water retention. In neuromuscular, there will be weakness, there will be tremors, asterixis, incoordination, hyperreflexia. Now, the things that see, this topic is too theoretical for me to keep on writing. Therefore, in this, I've written a lot of, I've used a lot of typed material, and this will be uploaded. So don't worry, it will be there with you for your reference. And we usually get a lot of practical questions from this topic and less theoretical questions. So try to imbibe the concept of each oxygen delivery device. All right. When do we give? I told you indications. Indications. Indications of oxygen therapy. So indication will depend on what you can measure. Can you measure tissue hypoxia? No. There is no direct measure of tissue hypoxia. We cannot directly measure tissue hypoxia, but we can directly measure the blood concentrations of oxygen, and that is what we keep as a target. We presume that if the blood concentration is low, then the tissue concentration is low, and if we increase the blood concentration, then the tissue concentration will increase. So we have two things. One, we have an ABG finding, that is an arterial oxygen concentration less than 60 mm of Hg. Another is a pulse oximetry finding where we say SpO2 less than 90%. SpO2 less than 90%. It is considered as acute hypoxemia. Again, look at the terminology, hypoxemia, that is decreased O2 concentration in the blood. Cardiac and respiratory arrest, no ventilation, no oxygenation, obviously O2 delivery will decrease. And shock or cardiac arrest, what will happen? Again, because your cardiac output will decrease irrespective of how much oxygen you have in the body, it will not get delivered. Hypotension, again related to cardiac output. Low cardiac output states with metabolic acidosis and respiratory distress, because your minute ventilation will not match your requirement. This is how we deliver the oxygen. This is the prescription. This is the prescription. So there can be a normobaric oxygen therapy and there can be a hyperbaric oxygen therapy. Normobaric is at atmospheric pressure. At atmospheric pressure. Hyperbaric is when you give oxygen therapy at more than 1 atmospheric pressure. This is when you want to increase the dissolved O2 content. Because with increased pressure, there will be increased solubility of oxygen in the plasma. So you use hyperbaric oxygen therapy in conditions where you cannot really do with the hemoglobin part. So what you do, you try to increase the dissolved O2 content. Okay. You try to increase the dissolved O2 content. Are you guys with me? Anybody apart from Bhargavi who has joined? Right. Now, normobaric oxygen therapy is then divided into low dependency, medium dependency, high dependency, and low dependency devices are then variable performance and fixed performance. Variable performance means variable FiO2. That means as the breathing characteristic of the patient will change, the FiO2 that is being delivered to the patient will change, and fixed performance means fixed FiO2. Fixed performance means fixed FiO2. All right. This is one type of distinguishing or differentiation between different O2 delivery devices. Now, what is this low dependency, medium dependency, high dependency? Low dependency means low dependence on the supplemental or support to the patient. So, supplemental oxygen alone is sufficient to correct hypoxia. Respiratory pattern is spontaneous. These are low dependency, which do not require any other support that is given to the patient. The patient is spontaneously breathing. Medium dependency, supplemental oxygen with some degree of respiratory assistance, like using a CPAP or BiPAP. So it is spontaneous, but you are supporting. So medium dependency. High dependency is supplemental oxygen with full respiratory support. That is your IPPV. That is your IPPV, where the patient is not breathing, you are only giving the breaths, right? So we are not going to discuss these two today. We are going to discuss the low dependency devices. We are going to discuss the low dependency devices, which are the variable performance device called as low flow devices, and then fixed performance device, that is high flow. Now there are a lot of books, and every book has little bit different aspect of what is a low flow device and what is a high flow device. But Oxford Emergency Medicine and Critical Care textbook, I found their justification as the best justification, and what they stated was very simple. If you divide the oxygen delivery devices based on flow, then they are low flow and high flow devices. Now, in normal quiet respiration, there is usually a flow rate, maximum flow rate of less than 30 liters per minute. This is your normal flow rate. So, low flow devices are which require lesser flow rates than patient's maximum flow rate, and one that require more than maximum flow rate is a high flow device. So traditionally what the patient delivers, so usually we say up to 15 liter per minute, that is what we use. 15 liters per minute is a low flow device, while more than 15 liters per minute is a high flow device. More than 15 liters per minute is a high flow device. All right, let's look at the choice of delivery system, which is based on what factors? Degree of hypoxemia, requirement for precision of delivery, patient comfort, and cost. These are the factors on which your choice of delivery will depend. Degree of hypoxemia is very important. Then how much precise oxygen do you want? Now there are certain conditions which require very precise oxygen concentration to be delivered to the patient. Can you tell me which are those conditions which require very precise concentrations of oxygen being delivered to the patient? Yes, right up your alley. O2 dependent breathing, that is patients with COPD. They don't have a hypercapnic. Yes, Bhargavi, very good. They don't have a CO2 dependent breathing, where the breathing rate is controlled by oxygen because of the down regulation of their CO2 receptors in the brain. So now they are oxygen dependent. So suppose you hyperoxic them, you give them more than required concentration of oxygen, they will go into hypercapnic respiratory failure, right? So here the precision of delivery is dependent on the type of the patient. Comfort is very important. Try giving somebody a non-rebreathing mask who is claustrophobic, they will not accept the mask. And of course, cost, especially in a country like India. Now, low flow and high flow devices, there are certain distinctions. It cannot deliver constant FiO2, a low flow device, while high flow devices usually maintain a constant FiO2. Flow rates are between 6 to 8 liters per minute. These deliver very high flow rate mixture of oxygen and room air, usually 4 times the actual minute volume. FiO2 varies with tidal volume. So if the patient is breathing shallow, there is less entrainment, so high FiO2. If there is hyperapneic or deep breathing, then more entrainment of room air, less FiO2. Examples are nasal cannula, oxygen mask, oxygen with reservoir bag. Used high flow devices are used in the treatment of hypoxic patients who depend on hypoxic drive to breathe and require controlled increments in FiO2. Young and vigorous patients with hypoxemia with ventilator requirement exceeding the capability of low flow systems like jet mixing venturi mask, reservoir nebulizer, and oxygen blender. So what you normally use every day in your ICUs, in your wards, is always a low flow device. Okay. Now try to understand how is there a variation of FiO2 in a low flow device. Now this should catch your attention. This part should catch your attention because this is what your examiners will expect from you. The moment you utter variable flow and a fixed flow device, this is what they are going to ask next. Okay. So what are we trying to do here is we are trying to see that what is the ventilatory minute volume of the patient, that is respiratory rate into tidal volume. That is what we are trying to see. And then we put a certain oxygen flow rate on the low flow device, and then we calculate the FiO2, that is the fraction of inspired air that contains oxygen. So let's say the patient is breathing very fast. So 750 ml per minute, 40 breaths per minute. So what would be the minute ventilation? 30 liters per minute. So deep breathing also, fast also, 30 liters per minute. Now the patient, you have given oxygen at 2 liter per minute, say nasal cannula. So 2 liter per minute of 100% oxygen and 28 liter per minute of air drawn into the mask, that is 21%. So what would be the total volume? 30 liters per minute. That would be the total volume that the minute ventilation that the patient is taking. So FiO2, 2 liter into 1%, 0.21% into 28 liter divided by 30. That is the total volume. So what did it come? 26%. So you were giving 2 liter per minute to a patient who is breathing at 40 breaths per minute, 750 tidal volume. He will receive 26% oxygen. That is only 5% above what you normally breathe. But suppose the patient is breathing at 500 ml per minute per breath and 10 breaths per minute. Then what will happen? The same calculation will change. Now 2 times of 1% and 0.21 into 3 divided by now 5. Divided by now 5 because the total flow rate is 5. Now it becomes 53%. So the same flow rate of oxygen gives variable FiO2. That is the variable flow devices or variable oxygen delivery devices. We divide low dependency devices into low flow and high flow. Low flow are nasal cannula, simple mask, reservoir mask. Reservoir masks are divided into partial rebreathing and non-rebreathing, while high flow systems are divided into venturi mask and high flow nasal cannula mask or blenders. Oxygen blenders, high flow nasal cannula, HFNC. Remember, unless and until specified HFNC, you will not consider them as high flow devices. So if the question says nasal cannula, always consider nasal cannula as a low flow nasal cannula. Always consider nasal cannula as a low flow nasal cannula. Never think, okay, if it is written nasal cannula, it might mean high flow nasal cannula. No, it doesn't work that way. Okay. Now, common low flow devices, you have nasal cannulas, which are prongs or spectacles, nasal catheters. There are transtracheal catheters, face mask, partial rebreathing mask, non-rebreathing mask, and tracheostomy mask. nasal cannula. We have all used it. Now I'm going to go little faster because this is all what you already know. I'm just going to debrief you on these O2 delivery devices. What are the advantages? What are the disadvantages? Ultimately, you have to understand the funda behind using each and every of the O2 delivery devices, in which condition you will prefer what. So nasal cannula is like the simplest device. What it does is you put the nasal cannula in the nose and it converts your nasal dead space into oxygen reservoir. So whatever is the nasopharyngeal and the posterior pharyngeal wall dead space, it replaces that with oxygen. So every time the patient breathes, so if the patient is breathing from nose or if the patient is breathing from the mouth, then this oxygen gets mixed with the oxygen that the patient is breathing, and that oxygen helps as a oxygen therapy. Now there are two soft prongs which are attached to O2 supply tubing. The flow rate is 2 to 4 liter per minute, delivers between 0.28 to 0.36. FiO2 is 20% plus 4 times the oxygen flow rate. This is like a rough estimate, right? And you do not increase more than 6 liters per minute. So it usually works between 1 to 6 liter per minute. That is the flow rate. And with every 1 liter increase in 1 liter increase in flow rate, there is an increase in 4% FiO2 above normal, that is 21%. That is a rough estimate that you use to calculate the FiO2 that is being delivered to the patient. Nasopharynx acts as a reservoir. Even if the patient is breathing from mouth, there will be Venturi effect which will cause entrainment of oxygen from the nasopharyngeal cavity, and it is available in different sizes and shapes. These are the common. There are curved prongs, then there are flared prongs, there is curved and flared prongs, there are straight prongs, and then there are prongs with ear guards. Okay, depending on what device is available at your place, there are different types of nasal cannulas. Different types of nasal cannulas. What are the advantages of a nasal cannula? It is ideal for patient on long-term oxygen therapy, LTOT. Long-term oxygen therapy like restrictive lung disease patient or cystic fibrosis patients or your pulmonary fibrosis patients or your patients with lung resections who have not who are always hypoxic, and these are patients who chronically, or neuromuscular disorder patients, these patients require oxygen therapy all the time. So you can't expect them to put on a mask. How will they eat? How will they talk? They will always feel claustrophobic. So you put a nasal cannula, and sometimes these patients they remain like this for years. Lightweight and comfortable, the patient is able to speak, eat and drink. Humidification is not required and low cost. Disadvantages: cannot provide high flows of oxygen, irritation and cannot be used in nasal obstruction, and FiO2 varies with respiratory efforts, and high flow rates are uncomfortable. So till you are at 6 liter per minute, everything is fine. But suppose you increase it to more than 6 liters per minute, then that flow of oxygen will cause nasal crusting, nasal mucosal damage, sometimes even bleeding. So you cannot use it in very high flows. You cannot use it in very high flows. Right? Advantages and disadvantages of nasal cannula. Advantages and disadvantages of nasal cannula. Right? Let's look at nasal catheter. Nasal catheter. Now, this is something that you guys will use less, but we use it very often. We use a strategy called as Thrive, that is trans nasal high flow oxygen delivery ventilatory exchange, where we put a catheter and put it a little deeper till the end of posterior pharyngeal wall where there is uvula, and then we give oxygen. So while we are intubating the patient, there is a high flow nasal cannula that is being delivering oxygen, that is called as apneic oxygenation. Very, very effective. This is nasal catheter, when you place a catheter in the nasopharyngeal cavity. Now, nasal catheter is usually a single lumen catheter which is lodged in the anterior nares by foam collar inserted below, just above the uvula. Flow rates usually 2 to 3 liter per minute. FiO2 is 35 to 40%. It should not be used when there is a nasal mucosal tear or suspected because risk of surgical emphysema, and deep insertion can cause air swallowing and gastric distension and must be repositioned every 8 hours. No advantages over nasal cannula. No advantages over nasal cannula. I'm here only just take a look at this before I move on. Just read this and imbibe this for a minute. Right? Now moving on. All right. Moving on to simple face mask. Now that is also called as Hudson's mask. It is also called as Hudson's mask. What we do, we use this volume, which is usually around 200 ml, as a reservoir. This acts as a reservoir for oxygen. It is called as Hudson's mask. This volume of the mask acts as a reservoir. Simple face mask. It is transparent. Capacity is 100 to 250 ml. Different oxygen flow rates produce highly variable and unpredictable FiO2. So you can't really say how much that the patient is going to get. Rebreathing of CO2 can occur if O2 flow rates are less than 2 liters per minute or if minute ventilation is very high. So there is no point in putting a O2 mask and then putting only 2 liters of oxygen. You have to start with minimum 3 to 4 liters of oxygen. 4 liters of oxygen delivers an FiO2 about 0.35 to 4, providing there is a normal respiratory pattern, and flow rates more than 8 liters per minute do not increase the FiO2. So its range is usually between 4 to 8 to 10 liters per minute. Advantage: less expensive, can be used in mouth breathers. Disadvantage: uncomfortable, requires tight seal, doesn't deliver very high FiO2s. FiO2 variable varies with breathing efforts, that is variable flow device, variable delivery device, interferes with eating, drinking, communication, and difficult to keep in position for long, and chances of rebreathing are very high. Chances of rebreathing are very high because we normally inspire through nose, but we expire through mouth usually. So when you are expiring through mouth, then there are very high chances of rebreathing. Especially if the patient has high minute ventilation, then it will not be able to compensate with that high minute ventilation. All right. So these are the advantages and disadvantages of simple face mask. Next is a partial rebreathing mask. Partial rebreathing mask. Now I really don't understand why they made this mask. We had the nasal cannula, we had the O2 mask, and then we had the NRBM, which is non-rebreathing mask. Now, NRBM is such a beautiful thing. I really don't understand why somebody needs to have a partial rebreathing mask. But then they have made it. There's a mask with reservoir bag of 1 liter capacity. Oxygen flows directly into the reservoir bag, which fills during exhalation, designed in a way that it captures exhaled gases from initial part of expiration, that is from dead space. So they wanted to conserve some of that oxygen that is coming from the dead spaces, useful in situation where supplies are limited. But practically, I don't see a point, because partial rebreathing, you don't know how much the patient is breathing, how much of that is getting entrapped, the exhaled dead space gases. So usually it is not a very useful device. Practically, FiO2 is between 0.6 to 0.8. Minimum 8 liters should enter the mask so that the CO2 gets exhaled out, and flow rate must be kept to keep the bag 1/3 to half fill at all times. That is the flow rate that is required. So it usually works between 8 liters to 15 liters per minute. The advantage is inspired gas not mixed with room air. So whatever the patient is exhaling out, along with that, whatever we are inhaling from the reservoir bag, and the patient can breathe room air through exhalation port if oxygen supply gets interrupted. So this is acting as a safety net. Suppose oxygen gets stopped and you are not aware, then the patient will not become hypoxic. There is a mask from which the patient cannot breathe if there is no supplemental source of oxygen. So the patient can still breathe because the holes will allow the patient to breathe from air. Disadvantage: more oxygen flow doesn't increase the FiO2 and interferes with eating and drinking, which is with all the masks except for nasal cannula. Non-rebreathing mask. Now this was the mainstay of the treatment in COVID because it gives you highest FiO2. Remember, NRBM is highest FiO2. That is why it is also called as high con mask or high concentration mask. Highest FiO2, therefore called as high con mask or high concentration mask. Now, this provides one-way valve between the mask and the bag exhalation port, right? So there is a one-way valve where between the mask and the exhalation port and mask and the bag. So when the patient breathes in, the patient is only breathing from the reservoir bag, which contains 100% oxygen. When the patient is breathing out, the exhaled gases, they move out from the exhalation port. The moment the patient starts to inspire again, the one-way flap valve closes and the patient starts breathing from the reservoir bag. That is why it is called as non-rebreathing mask. FiO2 is 95%, that can be achieved with an oxygen flow rate between 10 to 15 liter per minute. Now, this is under ideal circumstances. Usually, we get somewhere around 80 to 85%. Ideally, NRBM should not allow any entrapment of air, but we still keep some holes open in case the patient needs. The patient can inhale from outsides. Now, in non-rebreathing mask, there is a higher oxygen supply rates. Desirable cases where rebreathing of CO2 would be detrimental, for example, head injury. Best results are achieved with adequate flow rate, such as reservoir bag empties by no more than third during inspiration, by best seal possible between the mask and the face. So you try to avoid the entrapment of air from outside, and you try to make sure that the bag is inflated to at least 1/3 at all points of time. Advantage of a non-rebreathing mask: highest FiO2 without intubation, suitable for spontaneously breathing patients with severe hypoxia. Example, COVID. Severe cases of COVID. We have saved a lot of patients from NRBM. They have been on chronic oxygen therapy for a week, 2 week, 3 week, but this NRBM has saved them from intubation. The disadvantage is it is expensive, requires tight seal and is uncomfortable, interferes with eating and drinking, not suitable for long-term use, and malfunction can cause CO2 buildup and suffocation. All right. Now, these are the average flow rates and the FiO2 that they deliver. Nasal cannula 1 to 6 delivered FiO2 between 0.24 to 0.44. Transtracheal catheter zero point 0.4 to 0.5 to 4. FiO2 between 0.24 to 0.4. Oxygen mask 5 to 6 liters per zero point 0.4. FiO2 6 to 7 per 0.5. 7 to 8 per 0.6. Mask with reservoir bag 0.6 to 0.9. Non-rebreathing 0.6 to 1. Venturi mask 3 to 15. And I'll tell you, in Venturi mask there will be a fixed FiO2, that is because of the Venturi effect. So it is based on Venturi modification of Bernoulli's principle. The gas flow is sufficient to meet the demands of the patient, not synonymous with high concentration of oxygen. So remember, high flow or fixed performance device doesn't mean high concentration. High flow doesn't mean high concentration. Something that you have to keep in mind. High flow doesn't mean high concentration. High flow doesn't mean high concentration. It is not equivalent. High flow is when the flow rate of the gases that the patient is getting is more than the minute ventilation of the patient. That is high flow. Okay. Now, the proximal end of the mask consists of a Venturi device. The Venturi devices are color coded and marked with the recommended oxygen flow rate to provide with the desired oxygen concentration. Alternatively, a calibrated, attachable, adjustable Venturi device can be used. I'll tell you how it is. So, it is based on the principle of Bernoulli, which states that the total energy of a liquid flowing through a tube is constant. Try to understand what is this Bernoulli's principle. What it states that the total flow rate, the total energy of a liquid flowing through the tube is always constant. So, for any reason, if you accelerate the flow of this liquid, what happens? The kinetic energy will increase. So, automatically the potential energy should fall. Kinetic energy here is the velocity of the fluid. So, what would be the potential energy? It would be the pressure across the fluid. So, the moment there is increased velocity, the pressure across will fall. That is Bernoulli's principle. This Bernoulli's principle is taken into use to create an effect called as Venturi effect, where a constriction in the path of a flow of a liquid or here a gas creates a negative pressure on the walls surrounding, from which you can put another fluid. This entrained fluid will always be constant because it will always depend on the constriction, because the constriction will decide the velocity of the fluid. The constriction will decide the velocity of the fluid. Understood? So when you see a Venturi valve, different Venturi valves will have different calibrations or calibers or opening. So the smaller the caliber, the faster will be the flow rate, the more drop in the pressure, the more entrainment of the gases, the lesser the FiO2. And so for every FiO2 that you need, there will be a different valve, and every valve should have a different flow of oxygen that you keep. So here it is written 2 liter per minute oxygen will give 24%. So now what will happen? Even if the patient is breathing very fast, now the gases will the patient will take in more gases. Now 2 liter of oxygen, if the flow increases, again more entrapment, more oxygen will come, more air will come, and again it will be 24. If the patient is breathing less, then less velocity, less oxygen will come, again it will be 24. So at 2 liter per minute, irrespective of the patient's respiratory pattern, the FiO2 delivered would be 24. That is why it is called as fixed performance device. So see, I'll show you another table. These are color coded, and on each valve there is a flow rate of oxygen that you keep, as well as the FiO2 that is being delivered. Now there is an adjustable venturi valve where you can adjust what FiO2 you want. It will tell you what flow rate to keep. You keep that flow rate and you will get that FiO2. There is another jet mixing venturi mask or air entrainment mask, which essentially does the same thing. It is another name for venturi mask only. You can see you give 100% oxygen, it entrains room air, and that delivers the oxygen to the patient in a very specific FiO2. So it delivers fixed concentrations of oxygen. The size of the constriction determines the final concentration of oxygen. As the forward flow of inspiratory gases increases, the lateral pressure adjacent and perpendicular to the vector of the flow decreases, resulting in entrainment. The smaller the orifice, the greater the negative pressure generated. So more ambient air and lower the FiO2. I told you, smaller the orifice, lower will be the FiO2. So it can be 0.24, 0.28, 0.31, 0.35, 0.4 and zero point 0.6. So it doesn't mean Venturi is going to give too much of FiO2, but whatever value you will choose, it will give you fixed FiO2. There is no rebreathing and there is no increase in the dead space. These masks are recommended when there is a final oxygen, fixed oxygen concentration that is desired in the patient, that is patients with hypoxic drive, that is right up your alley, that is COPD. So I am rarely going to use a Venturi mask, but you as a respiratory physician, you will use Venturi mask a lot. Now this is a table which tells you what is the FiO2 delivered, what is the flow rate that you keep, what is the amount of entrapped air, and what is the total flow that goes to the patient. And see the figure of the total flow: 53, 45, 47, 45, 42, all 30, all more than the patient's minute ventilation, all more than the patient's minute ventilation. That is why they are called as high flow devices. That is why they are called as high flow devices. This is how a Venturi mask looks like. Now, how to calculate the device flow rate? So, device flow rate would be air is to oxygen ratio for an air entrainment mask at FiO2 40%. So, air is to oxygen ratio. So, basically divide the air by oxygen. So, how much would be the air? Whatever 100% minus the FiO2 that you are keeping for that particular valve, and how much is the oxygen, whatever FiO2 you are keeping, minus 21, that is the oxygen present in the air. So suppose it is 40% FiO2, so 100 minus 40, that is 60% oxygen and 19%, 60% air and 19% extra oxygen that you are giving. That is the ratio of air to oxygen is 3.2 is to 1. That is for every, suppose you set a 10 liter per minute oxygen, then the entrained air would be 3.2 times of that, that is 32 liter per minute, and the total flow rate would be 10 plus 32, that is 42. So if somebody asks you the total flow rate, that would be the air plus oxygen. So whatever oxygen you are keeping plus whatever is the entrained. For entrained, you need to calculate the air is to oxygen ratio. Now this is something which is like straightforward Venturi mask. What are the advantages and disadvantages? Advantages: fine control of FiO2. That is the biggest advantage of using a Venturi mask. Fixed, reliable and precise FiO2. High flow comes from air, saving the oxygen cost. So you don't need a machine to create that high flow. Can be used for low FiO2s as well. Helps in deciding whether oxygen requirement is increasing or decreasing because it is fixed. So suppose you put the patient on 28% oxygen and now the saturation is falling, that means the oxygen requirement is increasing. Disadvantages: uncomfortable, expensive, cannot deliver high FiO2s and interferes with eating and drinking. That is with all the masks. Now this is a ventilator type of device. This is a proper electrical device called as HFNC, and you will see a lot of HFNC being used in pediatric patients in NICU, but now we have started to use them in adults as well. The most important point about an HFNC is that there is a heated and almost completely humidified oxygen at a very high rates. up to 8 liter per minute for infants, but for adults 40 liters per minute. That is why it is called as high flow nasal cannula, and there is a specific cannula that is being, which is very snugly fitting into the nasal cavity. It is used in patients with respiratory distress or failure. Oxygen by humidified high flow nasal cannula may be tolerated, better tolerated than face mask, and it is something that you do just before you decide that I have to finally intubate this patient. You give them a trial of HFNC, and this is one of the disadvantages, that there is a possibility you might delay intubation. There is a possibility that you might delay intubation because you are giving a trial of HFNC. All right. Now, how does it work? What is the physiology behind use of HFNC? How is it different from nasal cannula? High flow washes out the carbon dioxide in the anatomical dead space. It washes out. It is such high flow that whatever the patient is expiring out, it washes out that CO2, acting as a reservoir of O2. It creates a positive pressure, that is PEEP. FiO2 remains relatively constant, and because it is warmed to 37 degree and completely humidified, the mucociliary function remains good and very little discomfort is reported. So it can be used for a longer period of time. See, this is an individual which is on HFNC and is talking. You set the FiO2, you set the flow rate, you also set the temperature, you can also set the humidity. Ultimately, it's an amazing device which acts as a device that you use just before you decide to intubate somebody. This is reservoir cannula, and this is a normal type of reservoir. Now I'm just showing you the image of a transtracheal catheter. It is nothing but a nasal catheter which you put through the trachea. The advantages, disadvantages are the same. Now, selection of the device. Now, these are the devices, but the most important thing is, how do you select these devices? Have you ever wondered how do you select these devices? So there are three P's: purpose, patient, and performance. Purpose, patient, performance. Purpose, goal is to match the performance characteristics of the equipment to both the objectives of therapy, that is purpose and patient special need. So idea is that all three things should come in the line. What is the purpose of giving oxygen? What is the performance of the device? And what is the patient's need? Purpose is to improve arterial hypoxemia. See, we always write hypoxemia, we never write hypoxia, because I told you oxygen therapy doesn't mean you are going to treat hypoxia. The patient factors in the selection are severity and the cause of hypoxemia, patient age group, whether infant, child, adult, or elderly, degree of consciousness and alertness, presence or absence of tracheal airway, stability of minute ventilation, and mouth breathing versus nose breathing. These are the few factors that you keep in the mind. In case of an acute exacerbation of COPD, HFNC or NIV, which is better before intubation, sir? You tell me. You tell me, you are a respiratory physician. What will you put? You will put HFNC, or you will put HFNC, or you will put NIV? You tell me. Acute hypercapnic exacerbation of COPD. That is the complete name. Acute hypercapnic exacerbation of COPD. What is your requirement? Increase in minute ventilation causing CO2 washout, or you want to increase the FiO2? Yes, always NIV. See, it's a special circumstance. In COPD patients, there is nothing much role of oxygen, right? Now, idea of oxygen therapy or oxygen delivery in a acute hypercapnic exacerbation of COPD is not oxygenation, it is CO2 washout. When you give an NIV, that interface, usually we use a BiPAP, and in that BiPAP there is effective exhalation of CO2 by increasing the minute ventilation. There is no augmentation of tidal volume. That is the differentiating feature between BiPAP and PSV. PSV augments tidal volume, but BiPAP doesn't augment tidal volume, but it recruits the alveoli, causing effective CO2 exhalation by improving minute ventilation, right? That is the difference. And That is why in acute hypercapnic exacerbation of COPD, you will always prefer NIV, and in NIV also you prefer a BiPAP. Now, this is a beautiful table, and you asked the question before, that is why I explained the answer. But this algorithm is what you have to keep pasted in front of your table or in your phone. And this is a very simplified strategy to using oxygen delivery devices. Let's first ask the first and the most important question. Patient with respiratory compromise or impending arrest. If the answer is yes, then what will you do? If the patient is in impending arrest or severe respiratory compromise, what will you do? Obviously, you will intubate the patient, right? Intubate. So if the patient is on impending arrest, intubate. If no, then ask the next question. Now, this is very important for you. Risk of type 2 respiratory failure, that is hypercapnic. If the answer is yes, then these are patients which are O2 dependent, that is COPD patients. So is there a role of higher FiO2? No. So your target SpO2 becomes 88 to 92%. So what will you do? You will start with a Venturi mask with an FiO2 between 24 to 28%, obtain ABG and reduce FiO2 if SpO2 is more than 92%. Then check for ABG. If ABG is showing acidosis, pH less than 7.35, PCO2 more than 45, that means the patient is not getting improved on this Venturi mask. So you will consider NIV or invasive. But if the patient is normal, more than 7.35, less than 45 PCO2, that means you will use Venturi mask with lowest FiO2 to keep the SpO2 between 88 to 92% and keep repeating the ABG after every half an hour or 1 hour. This is when there is a risk of type 2 respiratory failure. If there is no risk, then your target becomes 94 to 98%. Then you will look at the saturation. If the saturation is on the lower side, 85 to 94, or it is very low, less than 85. So you'll check with ABG. If PCO2 at any point is more than 45, it is type 2 respiratory failure. So consider invasive mechanical ventilation. That means there is hypercapnia and there is hypoxia. So no question, just intubate. If the patient has 85 to 94, start with nasal cannula or simple face mask. But if it is less than 85, then you require high concentration mask. Now, I have found this table to be extremely easy and useful. It is an extremely easy and useful table to decide which O2 delivery device to use. And basically, you have nasal cannula, you have normal face mask, you have a face mask with reservoir bag, and you have Venturi mask. Now, this is device-based performance, desired FiO2 level, and desired FiO2 stability. So, desired FiO2 level, if it is low, then if variable nasal cannula, nasal catheter, fixed is always air entrainment mask or HFNC. And this is based on that simple understanding that whatever you will require is what you will give. Let's see what you will do. Scenario 1, emergencies with suspected tissue hypoxia. So cardiac or respiratory failure, shock, trauma, carbon monoxide poisoning. What do? You want to achieve highest possible FiO2, ideally 100%. So if the patient is carbon monoxide or cyanide poisoning, you will prefer a hyperbaric system. And if the patient has any other thing, then you will choose ideally highest FiO2, right? So you will use a closed reservoir system or a true high flow system, that is mostly ventilator. All right. Scenario 2, critically ill adult patient with moderate to severe hypoxemia. Moderate to severe. So goal is to have PO2 more than 60, SpO2 more than 90. So you will start with reservoir bag or high flow systems to keep FiO2 more than 60%. Scenario 3, critically adult with moderate to mild to moderate hypoxemia. Like for an example, post-operative phase, recovering from myocardial infarction. So here FiO2 is not very important. So you will start with nasal cannula or simple face mask. All right. adult patient with COPD with acute on chronic hypoxemia. So now here is goal as adequate arterial oxygenation without depressing ventilation. So your target SpO2 85 to 92 with a PaO2 50 to 70. So here low concentration air entrainment mask. So Venturi mask COPD is something that should come naturally to you, right? Whenever there is a COPD patient, you will prefer a Venturi mask. Right now, there are few tables that I've taken from Oxford Critical Care, uh, and I told you oxygen therapy doesn't mean increased oxygen delivery, isn't it? So this is alternative methods to increase oxygen delivery because it is not always pertinent to keep giving oxygen to improve oxygen delivery. So what you will do, improving and safeguarding the airway, suctioning, manual maneuvers, airway adjuvants, supraglottic devices or endotracheal tubes, optimizing circulating volume to maintain tissue perfusion, enhancing cardiac output, correction of anemia to increase oxygen carrying capacity, avoiding or reversing respiratory depressants, establishing and treating underlying causes of hypoxemia, and non-invasive or invasive ventilation, including recruitment maneuvers. So, if you remember the O2 delivery equation, that is cardiac output into O2 carrying capacity, and O2 carrying capacity is hemoglobin bound and plasma, which is unbound or dissolved, then you will always know whenever you see a hypoxic patient, that is where you are suspecting tissue hypoxia, you will always look at the patient and you realize, okay, boss, I need to do these things. Okay. Now, this is just a table to tell you which conditions require oxygen in which conditions. So, medical emergencies requiring high concentration oxygen in all cases. Shock, sepsis, major trauma, cardiac arrest, resus, anaphylaxis, CO poisoning, cyanide poisoning, diving and altitude emergencies where you require high concentration always. Medical emergencies where patients are likely to need oxygen therapy, that is ranging from low to high concentration depending on disease severity, with target saturation between 94 to 98%. This is what you are going to treat more oftenly: pneumonia, asthma, acute heart failure, pulmonary embolism, where you have target is 94 to 98. Medical emergencies where patients are likely to need controlled oxygen with a target saturation between 88 to 92. Again, something that you will need. Acute hypercapnic exacerbation of COPD, acute illness with patients with cystic fibrosis, obesity, hypoventilation or obstructive sleep apnea, and chronic neuromuscular or musculoskeletal disorders. Medical emergencies where oxygen is advised only if the patient is hypoxemic. That is myocardial infarction, you don't always give oxygen. Stroke, ongoing management of survivors of cardiac arrest, sickle cell crisis or acute anemia, obstetric emergencies, poisoning, and metabolic and renal disorders with tachypnea due to acidosis. You only give oxygen if there is a evidence of hypoxemia. And other non-emergency conditions where you give oxygen, operations and procedures involving sedation, long-term use in pulmonary disease, assistance in pneumothorax resolution, and promotion of wound healing, including necrotizing fasciitis. No, 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 no. You are getting absolutely confused. In cardiac arrest, you only give oxygen in ACLS. In ACLS, right? But before you reach ACLS, you have to do CAB. And what is CAB? Compression, airway, breathing. So once you are doing compressions and airway and breathing, the next step would be to get an AED. If AED comes, defib, ACLS team comes, they start with oxygen, they take over, but the first and the most important priority is defibrillation. Whenever you use during cardiac arrest, you always use 100% oxygen. That is, you give it through an ambu bag, because now you are using either a mask, bag mask ventilation or a tube ventilation. So remember, in cardiac arrest, whenever you will give oxygen, it will always be 100%, but oxygen as a supplemental therapy is only given in ACLS. In BLS, it is just mouth to mouth or mouth to mask. Now, why are we worrying about oxygen so much? Because oxygen can be toxic. Now, there are cellular mechanisms of oxygen toxicity. We know every time we have oxygen in the body, oxygen gets broken down, and some oxygen they forms free radical, and these free radicals they go and start damaging the organs. Now normally we breathe 21% oxygen, which produces minimum amount of free radicals, which are then taken care by the antioxidants. But in disease processes, two things will happen. One, you will use higher fractions of oxygen, so more volume of free radicals will be produced. Second, because of the cellular mechanisms, cellular death, these antioxidants will also become lesser in the body. So there will be an imbalance which will cause more production of free radicals, which will cause free radical injuries. And this can present as a multi-system disorder. Eyes, there will be visual field defect, nearsightedness, cataract, bleeding, fibrosis, seizures in central nervous system, in respiratory, jerky breathing, irritation, coughing, pain, shortness of breath, tracheobronchitis, ARDS, and in muscles twitching. These are certain things that you need to remember, that oxygen, why it is called as a drug, because oxygen therapy can lead to over of oxygen therapy can lead to overdoing of oxygen therapy can lead to toxicity. All right. So my purpose today, I was being told to teach respiratory physicians about O2 delivery devices. So my purpose today was not to only tell you that okay, there is a device like this which gives this, device like this which gives this, but you to make you understand that don't treat oxygen as some standby. Don't treat oxygen as a thing that you can just give anytime you want. Treat oxygen as a drug, just like you prescribe a drug. So you always think of indication, you think of the dose, you think of routes of administration, you think of monitoring that therapy, and you think of side effects. Whenever you give oxygen to your patient, always think of these five things before you go ahead and you give this drug to the patient. So this is what I wanted to discuss. Thank you so much. I hope you know I'm Dr. Anshul Diwakar and I'm an anesthetist. And this is something which I wanted to discuss as a my part of discussion for you all. Feel free to contact me if you have any doubts. You can always message me on, you can follow my page on Instagram, Anesthesia Shots by Anshul. That is predominantly for anesthesia residents, but that is fine. You can also message me, and you can always WhatsApp me as well. So I hope this topic is making sense to you. If there are any more doubts in oxygen therapy, feel free to ask me. All right. So thank you so much. And if there are any doubts, then I'm waiting. Otherwise, I'll hang up. You're welcome, Dr. Ghosh. Thank you so much. You have been active and you have been asking questions. That is a very, very good thing. Right. So I'm giving you my WhatsApp number, which is 79744 888676. I only give it at the end so that people who have the patience to attend the session till the end, only those people should get an opportunity to ask doubts to me. You can always WhatsApp me. Please don't call me. I might not be able to pick up your call. But yes, do WhatsApp me, and I will definitely get back to you with an answer. Ah, wonderful, Dr. Ghosh. That is so nice to hear. Our students doing such good in life is something that makes us proud. So, all the very best. And I'll see you guys around. Okay, good night.